Thank you, Professor Ali, for this nice introduction. I'm going through the subject immediately. My topic will be functional dyspepsia. Uh, it's a very common disease, as you know, and the patients with functional dyspepsia are comprising a very major sector in the eye clinic. So the importance comes from here. The term dyspepsia is derived from the Greek words dys and peptin, which means bad digestion. But actually, this is almost a misnomer because the problem is far beyond this. Starting with Rome criteria, in Rome 2, it was defined as pain or discomfort centralized in the upper abdomen. But also, this was far beyond the truth because we found that a syndrome has many variety of symptoms described as epigastric pain, bloating, and nausea. Of course, you know that the types of gastrointestinal disorders, two main uh, items, organic GI disorders, which means that conventional diagnostic tools or means identify the underlying disease, and the functional disorders, which is up to 50% of patients. Here, the conventional diagnostic means in the form of endoscopies, radiology, lab works, fail to explain the thing. In these patients, symptoms are caused by disturbances in the GI motility and pain perception. Keep in mind that some medications commonly cause dyspepsia, and you have to review the history of your patients thoroughly, like the aspirin and NSAIDs, COX-2 inhibitors, iron, potassium supplements, and so on. So, according to the site of the disease or the affection of the gut, they classified functional dyspepsia, the functional disorders, into many subgroups. If it affected the esophagus, it can lead to functional heartburn, the functional chest pain, functional dysphagia, globus, and so on. If it affected the gastroduodenal area, we can encounter functional dyspepsia, leaching disorders, rumination syndrome. If it affected the colon, we can, of course, got the irritable bowel syndrome. Affected the rectum, we can encounter functional fecal incontinence and functional defecation disorders. So, Rome 3 started to put a conclusive or a more decisive criteria for functional dyspepsia. They said that functional dyspepsia is limited to 4 cardinal symptoms: postprandial fullness, early satiation, epigastric pain, and epigastric burning. And they proposed that they have to divide the patients into two major or two main subgroups: postprandial distress syndrome, which is characterized by the postprandial fullness and early satiation, and the epigastric pain syndrome, which is characterized by the epigastric pain and epigastric burning. This is the journey of putting criteria for the functional disorders of the gut, IBS and dyspepsia, ending with Rome 4, which at 2016. This is Rome 4, which explained or raised the possibility of that these functional lesions are due to disorders mainly of the gut-brain interaction. It was a work of a heavy work of many specialists in this field, And they stated that it is similar to Rome 3, but here the changes or the difference is that they stated that symptoms have to be severe enough to interfere with the usual activities of the patient. I mean, many patients may complain interruptedly from some epigastric fullness, some epigastric pain, but this is not the true functional dyspepsia patient. He has to be suffering a lot from this lesion, and it should occur at least 3 days per week over the last 3 months. This is for the early satiation and postprandial fullness, which means the postprandial distress syndrome. And for 1 day per week for the epigastric pain or burning problem, which is the epigastric pain syndrome. This symptom onset must be at least 6 months prior to the diagnosis. And they claim that it is an interruption in the brain-gut axis. The GI system is innervated by a specialized network of nerve cells, which is the enteric nervous system. This enteric nervous system acts on the smooth muscles surrounding the intestine to control its motility. The enteric nervous system is controlled from the brain by efferent autonomic nerves and also connected to the brain by connected from the brain by afferent nerves and connected back to the brain by efferent autonomic nerves. This two-way communication between enteric nervous system and central nervous system is called the brain-gut axis. Any disturbance in this axis may cause abnormal perception of visceral events. So the pathophysiology could be a visceral hypersensitivity, which is proposed to be the main underlying mechanism in the epigastric pain syndrome subgroup, while disturbed motility, including the impaired gastric accommodation to a meal and delayed gastric emptying, are postulated to be the causative mechanism in the postprandial distress subgroup. So it could be motility disorder, visceral hypersensitivity, and very important point is the H. pylori infection, and all, of course, the central nervous system disorders. It is very wide. The prevalence of functional dyspepsia is very common. About 25% of people in the community each year report chronic or recurrent pain or discomfort in the abdomen. And it is consistent around the whole world. Only a minority can have chronic peptic ulcer disease, which means organic lesion, but the majority has functional dyspepsia. The prevalence is lower in elderly, so be careful when an old man or old woman started to complain. Don't assume that it's simple functional dyspepsia, and overall men are more affected than women. Although functional dyspepsia is not life-threatening condition, but it impairs the quality of life and has a significant negative impact on work productivity and increases healthcare expenses for both the patients and the society. And from here, it comes the importance of dealing and treating functional dyspepsia. So, 70% of functional dyspepsia is functional, which means there is no clear cause, and about 3% or 30% only you can find an organic cause. It is a problem related to the gastroduodenal region. And these are many studies clarifying that the majority of patients with dyspepsia are having no abnormality for this disease. So when you do upper endoscopy and you find that the patient is normal, don't assume that there is nothing, but think about the functional disorders like the functional dyspepsia we are speaking about. So rule of endoscopy. When to do endoscopy for those patients? The majority of patients with dyspepsia will have a normal endoscopy. But gastric and esophageal carcinoma were rare, less than 1% from those patients. So prompt endoscopy does have some clear advantage in making a firm diagnosis and also assurance of the patient that he has nothing serious for his complaint. But there are substantial disadvantages of performing prompt endoscopy for all cases. Of course, cost to both patients and society, and also risk-benefit ratio becomes more in view of large population burden. The low rate of organic pathology, less than 10% for peptic ulcer and less than 1% for malignancy, don't justify performing endoscopy to all patients with dyspepsia. This is supported by the evidence that the onset of the cost of detecting each case of upper GI cancer among patients with dyspepsia could cost more than $80,000. So the risk of malignancy begins to be rapidly rising after the age of 55 years, keeping in mind that there is no absolute age for malignancy. So proceed with endoscopy rather than empiric therapy in older individuals who develops new onset of dyspepsia. For younger patients, it's unlikely to identify a serious lesion with no, of course, alarm signs. So it is targeted endoscopic examination in these young patients. A prospective study in UK evaluated over than 4,000 patients who underwent endoscopy. They found that 3% had malignancy. 85% of these patients had already alarm signs and 15 didn't have, but their cancers were more curable because it was diagnosed early. So the protocol of management of dyspepsia postulated by Talley, if the patient has age 55 or more or have alarm signs at any age, proceed with endoscopy. If the patient had age below 55 and with no alarm signs, it depends about your area. If you have an area with low prevalence of H. pylori infection, you start with proton pump inhibitors or acid suppression. If it succeeded, you continue with this. If not, you shift to prokinetics. If succeeded, continue. If not, here you have to test and treat for H. pylori infection. And if the symptoms persist, you go with upper endoscopy. On the contrary, if you have an area with high prevalence of H. pylori, you start with test and treat for H. pylori, then PPI and prokinetics, and lastly, endoscopy. Acid suppression with PPI mainly could be very beneficial in controlling symptoms of functional dyspepsia, both sure for the epigastric pain syndrome, but also for the postprandial distress syndrome. This is by decreasing the gastric secretion volume, which is about 1 to 1.5 liters of acid per day. So this improves the postprandial fullness. If succeeded, you should continue for 8 weeks and then on-demand therapy. Diagnosis of functional dyspepsia is based only or mainly on the clinical symptoms and the exclusion of organic diseases. But if there are alarm signals, you should investigate with the endoscopy or radiology or lab tests. In case of suspected biliary or pancreatic diseases, you go with ultrasonography. According to the American College of Gastroenterology and the Canadian Association of Gastroenterology guidelines, they recommend that specific motility studies should not be performed routinely for all patients with functional dyspepsia. However, those with severe symptoms should be investigated if they fail to respond to the empirical therapy. Fundal accommodation can be quantified using a gastric barostat or single photoemission computed tomography, while delayed gastric emptying can be investigated using the scintigraphy or the radioactive meal or markers. breath tests, electrogastrography, and wireless motility capsule. A hint about this wireless motility capsule, which is called the Smart Pill. It's an FDA approved. It's like the video capsule, but with no camera. It's only houses sensors for pH, temperature, and pressure monitoring. It transmits samples data once every 20 seconds and in the first 24 hours and once every 40 seconds thereafter. The GIT transit time is the time interval between ingestion of the capsule to its expulsion. This is recorded by the change in the temperature from the room temperature to the body temperature. The gastric residence time can be measured as the difference between the time of ingestion to an abrupt rise of pH more than 4, because this means that the capsule entered the duodenum with its alkaline content. The intestinal transit time is the difference between the GIT transit time and the gastric emptying time. There is lower pH in the cecum than the terminal ileum because here we lack the alkaline intestinal juice. So this predicts that the capsule entered the proximal colon. The small bowel transit then is the time period between the pH rise in the proximal duodenum to the pH drop in the cecum, while the colon transit time is the duration of the time capsule spends in the body after entering the cecum till expulsion from the body. A hint of prokinetics, because it is a cornerstone in the treatment of many patients of functional dyspepsia. We started long ago with metoclopramide and domperidone, because these are dopamine D2 receptor inhibitors. Of course, now there are concerns about the safety of domperidone for the cardiac problems. So now there is warning about long use of this, and also be careful in old age. Cisapride was a very good drug, 5-hydroxytryptamine 4 stimulator, but it was withdrawn from the market for cardiac events. Now we have etopride, which is dopamine D2 receptor inhibitor and acetylcholine esterase inhibitor, and the musapride, which is selective non-cardiac amine 5-hydroxytryptamine agonist. The etopride has synergistic effect by inhibiting the acetylcholine esterase and also by inhibiting the D2 receptor in the stomach. It has no drug interactions because it is metabolized by the flavine monooxygenase, has no effect on the cytochrome P 450, and so it has no metabolic interactions. Of course, prolactin, hyperprolactinemia was a problem with the old drugs, but in a study formed to compare these drugs with etopride, they found that etopride must have a dose more than 30 milligram per kilo to induce some hyperprolactinemia compared to domperidone, which is only 3 milligram per kilogram, and metoclopramide, which is 1 milligram per kilogram. Cisapride was very effective, but it affected the QT interval, leading to cardiac problems. The etopride was found to have no effect on QT interval, as we see in this cartoon. The effect on the CNS, etopride is highly polar. It hardly penetrates CNS. It does not cross the blood-brain barrier. So there is no extrapyramidal manifestations like the metoclopramide or the domperidone. And so it has safe effect on the brain. Also, they said etopride relieve also symptoms, and it has an anti-emetic effect. And also in patients with GERD, Inouye found that about 23% of patients showed marked improvement in symptoms, and in about 66% of patients there is moderate improvement, and also endoscopic findings of GERD improved in about 1/3 of patients. Musapride is another prokinetic, but it is 5-hydroxytryptamine 4 agonist, and also it is safe on the heart because it has no effect on the 5-hydroxytryptamine 4 receptors of the heart. They studied it in diabetic gastroparesis, and they found that the electrogastrographic waves were significantly increased, and there was a corresponding significant improvement in the number of radio-opaque markers emptied from the stomach. Acutiamide is a muscarinic receptor antagonist approved only in Japan, 2012. It's acetylcholinesterase inhibitor, and they claimed that it improves gastric accommodation, and also it may adjust the activity of brain-gut axis through decreasing the expression of stress-related genes in the brain stem. Neuromodulators are very important tools and weapons in this problem. Antidepressants and anxiolytics in low doses are used in treating refractory functional dyspepsia patients with marked stress and psychological disorders through also their pain modulating properties at various levels of the brain-gut axis, as we explained. Many patients still are refractory for all these treatments, so some complementary and alternative therapies emerged. Phytotherapy, which means herbal therapy, especially in Asian countries like peppermint, chamomile, and licorice. Acupuncture was claimed to have some role in this area. And lastly, psychotherapy like hypnotherapy. And thank you very much.